And so this is very simple algorithm that I use in clinic, and as very well explained by Dr. Desai and others on the panel, it is very important to rule out or assess for the presence of actionable mutations for which we have a targeted therapy option in the first-line setting. Once we have ruled out that possibility, if we show that and prove that there's no targeted therapy option we can utilize as the frontline option, then I think about using immunotherapy-based treatment options in almost all patients, except for a few minor exceptions. If the patient has PD-L1 expression high, defined by at least 50%, I think there are two options. One is to use the PD-1 inhibitor monotherapy, or even we can consider using chemotherapy and immunotherapy combination. And this regimen, the combination regimen, I think about using even in the setting of PD-L1 high, at least 50%, if the tumor burden is high and I want to shrink the tumor as much as possible by with the help of chemotherapy being added to the immunotherapy. For those with PD-L1 less than 50%, I tend to think about using chemotherapy plus immunotherapy combination if the patient is a great candidate for the combination treatment. And we discussed a dual immune checkpoint blockade, and this is something I think about using in certain subgroups of patients. I think we need better biomarkers to identify those patients who benefit from CTLA-4 inhibitor addition to this treatment regimen. So to conclude, going back to the case, this is, again, a 76-year-old patient who had a surgery and then chemotherapy many years ago, then recurred with a stage 4 disease with PD-L1 expression 50%, and then KRAS G12C mutation. After discussion about different treatment approaches, we opted to use immunotherapy alone, pembrolizumab, given the high PD-L1 expression, and at the time the tumor burden was not deemed to be very high because the disease was pretty limited in the chest at the time, without any evidence of metastatic disease in the abdomen, pelvis, or brain. And so the patient had a response, if not CR, if not complete response, but almost complete response with the pembrolizumab, and he received that for 2 years. And after discussion, we opted to discontinue the treatment and just watched him. And so recently I saw the patient, before and after baseline, and 36 months after initial diagnosis of stage 4 disease. The patient has been doing very well off therapy for 1 year, enjoying his life. And so this was one of the sort of long-term and durable response that I saw with the immunotherapy. Thank you very much for your attention.